A chemical injury occurs when any type of chemical is instilled in the eye, for example, acids, hydrochloric acid, sulfuric acid, alkalis, ammonia, sodium, lime, etc. Prognostic factors. The severity of a chemical corneal injury is determined by the following. pH. Alkaline agents generally cause more severe injuries than acids, although very acidic solutions may behave similarly. Most domestic chemical agents are alkaline rather than acidic. Duration of contact. Corneal involvement, surface area. Limbal involvement. Corneal re-epithelialization relies on migration of the limbal stem cells. Conjunctival involvement, blind-ended sacs that may retain chemical and cause continuing ocular damage. Associated non-chemical injury, blunt trauma. Clinical features: paralimbal ischemia/limits, blanched vessels with no visible blood flow, corneal epitheliopathy, punctate to complete loss, corneal edema, corneal stromal necrosis. Conjunctival injection or ischemia, beware the white eye, plus or meniscemosis, hemorrhage, epithelial defects, ulceration, necrosis, or complete loss of conjunctiva. Anterior chamber activity and fibrin, traumatic mydriasis, increased intraocular pressure, consider TON open, rather than Goldman. Scleral necrosis, vitritis, necrotic retinopathy. Complications. Conjunctival burns, cicatrization, scarring, symblepharon formation, loss of goblet cells, keratinization. Significant limbal ischemia, conjunctivalization, vascularization, and opacification of the cornea. Full thickness burns, scleritis, vitritis, retinitis, glaucomatous optic neuropathy or hypotony, iris, ciliary, and lenticular damage, may progress to phthisis bulbi, very poor prognosis. Periorbital burns, first per second/third degree chemical burn. Workup. History. Time of injury. Specific type of chemical. Time between exposures until irrigation was started. Duration/amount of and type of irrigation. Eye protection. Sample of agent, package/label, or material safety data sheets are helpful in identifying and treating the exposing agent. Slit lamp examination with fluorescein staining. Eyelid aversion to search for foreign bodies. Evaluate for conjunctival or corneal ulcerations or defects. Check the intraocular pressure, IOP. In the presence of a distorted cornea, IOP may be most accurately measured with a tonopen, pneumotonometry. Gentle palpation may be used if necessary. Treatment. Immediate irrigation, neutralization of pH, 7.0 to 7.4, by irrigation before full history and examination. Test pH with litmus paper, then instill topical anesthetic, insert a speculum, and irrigate with water, normal saline, Ringer lactate solution, or Hartmann's solution through 4 tubing, and deliver a minimum of 2 liters or until pH is normal. Never use acidic solutions to neutralize alkalis or vice versa, as acid-base reactions themselves can generate harmful substrates and cause secondary thermal injuries. Acute, all injuries. Admit, if severe or any other concerns. Topical antibiotics, prophylaxis, for example preservative-free chloramphenicol 0.5% 4 times daily. Topical cycloplegia, for comfort/anterior chamber activity, for example preservative-free cyclopenolate 1% thrice daily or atropine 1% once daily. Topical lubricants, preservative-free, for example Carmelos 1%, 1 hourly day and night plus liquid paraffin. Oral analgesia, for example paracetamol plus or minus codeine. Acute, severe injuries. Admit and consider. Topical steroids, for example prednisolone 0.5 to 1% initially 4 to 8 times daily for 10 days. Topical ascorbic acid, for example sodium ascorbate 10% up to 2 hourly for 10 days. Oral ascorbic acid, for example 1 gram twice daily. Systemic tetracyclines, for example doxycycline 50 to 100 mg once daily or oxytetracycline 500 mg 4 times daily for 3 months. Tetracyclines contraindicated in children under 12, in pregnant/breastfeeding women, and in hepatic and renal impairment. Ascorbic acid should not be used in acid chemical burns. Acute, injuries with raised IOP. Acetazolamide 250 mg 4 times daily plus or minus topical beta blocker, for example timolol 0.5% twice daily. Alpha agonists should be avoided because of their vasoconstrictive properties, especially if limbal ischemia. Long-term, complicated cases, poor corneal healing, medical treatment for persistent epithelial defects. Surgical treatment includes techniques to assist epithelial migration and re-epithelialization of the cornea. Obliterated fornices and pseudopterygium formation. Consider pseudopterygium excision, together with conjunctival autograft or amniotic membrane facilitated by anti-proliferative MMC. Fornicele reconstructive surgery, including division of symblepharon and mucous membrane or amniotic membrane grafting, AMG. Corneal opacification. Consider limbal epithelial stem cell transplantation followed by penetrating keratoplasty, PARC, if adequate tear film. In bilateral cases, keratoprosthesis remains a surgical option in severely damaged eye. Thank you.